Today's topic of discussion is trigeminal neuralgia. Also known as tic douloureux. Tic douloureux. Tic douloureux. What do you mean by tic douloureux? Tic is an involuntary spasmodic action of facial muscle. And douloureux is pain. This is nothing but whenever there is this disease is present, and when there is a severe pain to the patient winces. The patient winces the muscles. There is wincing of the muscles. So coming to the definition part, definition of trigeminal neuralgia, it is defined as a severe paroxysmal episodes of excruciating, lancinating, stabbing type of pain in the area of distribution of the branches of trigeminal nerve, and always associated with trigger points. So the main thing which is very important in this definition is your trigger points. This disease is always associated with trigger points. So again, I am telling the definition. It is a very severe kind of paroxysmal episodes of sharp, lancinating, stabbing, excruciating type of pain in the areas of distribution of the branches of trigeminal nerve, and always associated with the trigger points. And this disease is also known as tic douloureux. I have explained what is the meaning of tic, what is the meaning of douloureux, and what happens to the patient. Wincing of the face, wincing of the muscles of face. Wincing of the muscles of face. There is an involuntary spasmodic action of the face whenever the pain starts. So coming to the clinical manifestation, I have already explained it, that it is a very sharp pain, it is a very excruciating type of pain associated with trigger points. That's it. Upcoming lecture. So the clinical manifestation of trigeminal neuralgia. Trigeminal neuralgia, first comes your site. The site, it can be most common. There are three divisions of trigeminal nerve: V1, V2, V3. V1 is your ophthalmic, and V2 is your maxillary division, and V3 is your mandibular division. So the most common site is mandibular more than maxillary, V2 more than V1. So V3 is more than V2 more than V1. Now the onset of this disease, it is of sudden onset. This disease is of sudden onset. It is not like other pain which are gradually building up, It is not like other which are gradually building up. So it is of sudden onset. Again, I am telling you, this disease is of sudden onset. Now coming to the characteristics of this pain, the pain which is caused due to trigeminal neuralgia. The characteristics of the pain, I have already described in the definition that it is a very severe, sharp, lancinating means cutting, lancinating, excruciating, pain, and this pain is of brief duration. The duration is also brief. That is 1 to 2 seconds, at max 1 to 2 minutes. So this was about the characteristics of the pain. Now coming to the radiating nature. So we'll see if this is the face and this is the angle of the mouth. It can radiate up to the ear, it can radiate up to the eye, it can radiate up to the nostrils. So depending upon the branch involved, either V3, V2 or V1, the pain can radiate to this area, but it is starting from the angle of the mouth and associated chin area, and it can radiate up to the ear if V3 branch is involved. If your V2 branch is involved, and if your V1 branch is involved. So likewise, now coming to the most important point, the exacerbating factors, or we can also say the triggering factors, triggers or exacerbating factors, triggers. Now there can be of two types. Triggers can be of two types. One is your movement and other is your tactile. Normally in this disease, what happens, all those stimulus which are non-painful, which do not produce any pain, those non-painful stimulus can lead to this kind of development of the pain, and it can be due to the movement, it can be due to the simple touching, and any pain which is originating from the non-painful stimuli, we call that allodynia. So there can be movement allodynia, or there can be tactile allodynia. Now example in movement allodynia, simple chewing. While chewing, the pain can occur. While smiling, the pain can occur. So these things like chewing. Chewing is it is not a painful thing. Whenever you do mastication or you do masticatory action, it is not painful. Smiling is not painful. But these non-painful activities can lead to trigeminal neuralgia. Tactile allodynia, the examples like simple, like we can say in men's shaving. While shaving, the pain can aggravate, or by simple touch on the cheek, or we can say if we are washing the face, and also it can be due to applying facials by the females. So these are the certain trigger points. And even one more, a blow of wind while you are sitting on a bike, the blow of wind can also aggravate this pain. So you can see how miserable the life of patient in this type of disease can happen. Simple movements like chewing, smiling, even shaving, touching the cheek, light touch on the face, or washing the face, blow of the wind on the face can aggravate this kind of pain. Now we can go to the another characteristic, that this disease, the severity, as I've told you, the severity of the disease, it is very important. It is very, very severe. It is paroxysmal episodes, multiple episodes of the pain, lasting for few seconds, and it is continuous throughout the day, having a very little remission period. I mean, you can have 5 to 10 attacks or more than 10 attacks at a regular interval, then a small remission period of 1 to 2 hours, and then again the attack can start. So the severity of the disease, again I am telling you the definition. It is a severe, paroxysmal, sharp, excruciating, lancerating type of pain along the distribution of the branches of trigeminal nerve associated with trigger points. This was the definition I explained in the previous lecture. Now the etiological factors. Etiological factors. Etiological factors, genetics plays an important role. Then your some aneurysmal blood vessel pathology, aneurysms, and some tortuous course of veins. These can lead to the development of the disease which is known as trigeminal neuralgia. Coming to the differential diagnosis, there are many differential diagnoses. There are many pain which are originating especially from the orofacial region, and the most common cause of orofacial pain, is your pain which is from teeth and gums and temporomandibular joint. So this is the most common cause of pain from the orofacial region. So before when you are diagnosing the case of trigeminal neuralgia, you have to first evaluate the oral cavity, you have to first evaluate the TMJ, exclude them, and then move forward for the diagnosis of trigeminal neuralgia. Then migraine can also be the cause of heavy, very, it is a very painful situation in the orofacial region. It is very, it's like a very heavy feeling, but the main difference between the trigeminal neuralgia and migraine is that trigeminal neuralgia pain is superficial pain. It is very sharp, but the migraine pain is deep-seated. And it lasts for long duration. Trigeminal neuralgia pain does not last for long duration, it lasts for only few seconds. But the migrainous pain, it is very deep-seated, it can last for long duration. Then there is cluster headache. This type of headache occurs in the periorbital region around the orbits. You can have a very severe pain around the orbit, and there will be associated features also, like there will be lacrimation, excessive lacrimation, which is known as epiphora. So these are some associated. Along with this, there can be increased nasal secretions also. Associated features are also present in migraine, like, yes, patient does not like lights, photophobia, patient does not want to hear voice, phonophobia. Basically, migraine patient wants to sit in a room which does not have light, it should not have any noise. So in trigeminal neuralgia, you can do a differential diagnosis, you can exclude that, but the trigeminal neuralgia cases, associated symptoms are not present. There is no sensory deficit. So we can also say that in trigeminal neuralgia, there is no sensory deficit. That means the neurons which are present, the neurons which are carrying the sensation does not have any pathology regarding loss of sensations. And also there is no interictal numbness, no interictal numbness. It means that in between the attacks, the patient does not have any feeling of numbness, no sensory loss. So we can exclude these diseases like migraine, cluster headache, sinusitis. Sinusitis pain is basically present on the frontal region and on both sides of the sinus. So this type of pain, this is your sinusitis pain. And cluster headache pains are around the periorbital area. There is one more headache which is known as temporal arteritis, which is along the ear and radiating towards the head. So this type of pain is also a very typical type of pain, and it is associated with blindness also. You can feel the auriculotemporal nerve which becomes very hard and cord-like. You can feel the pain here, you can feel the nerve also. And in migraine, half of the face, including the head, can be involved. And also there is one more headache which is known as tension headache, which occurs over the entire head. You feel like some weight is put on your head. So you can exclude these type of orofacial or some pain regarding the head and neck region. Now coming to the pathophysiology, how does this neuralgia occurs? Suppose this is your trigeminal ganglion. This is your trigeminal ganglion, and it is giving your three branches. This is your three branches. This is V1, V2, V3, and it is centrally connected to pons. This is pontomedullary junction, spinal cord. So the cause of this disease, that there is a vessel which actually impinges on the sensory nerve root of the fifth cranial nerve, and this vessel mostly it actually bulges down. It because of the tortuous course, it bulges down over the surface of the nerve, and it constantly irritates the nerve. And this nerve, this artery is known as, this is a vessel, and this artery is known as superior cerebellar artery, which is the branch of basilar artery, supplying the superior surface of cerebellum. It actually puts the weight, and constantly when it is pulsating, it is constantly irritating the surface of the nerve. Now, as you know that this surface, this nerve, the sensory root is covered by the myelin sheath. This sensory root is covered by the myelin sheath. It is covered by the myelin sheath. Because of the constant irritation of this, because of this vessel, this myelin sheath gets removed. So you can see the myelin sheath is removed, and the vessel is here, and the neurons are exposed. You can take an example of a wire which contains a copper wire covered by the rubber tubing. So if you remove the rubber tubing, the copper wire is exposed, and there are chances of short circuiting. So if you take this section of this sensory root carries multiple fibers. One fiber which is going toward the central nervous system is your A delta fiber, which carries the proprioception. Then this is your A beta fiber, which carries your fine touch, 2-point discrimination sensation. And then there is A delta fiber, which is actually carrying the sharp pain, and this C fiber, which is actually carrying the dull pain. It is the most myelinated fiber. A beta is least myelinated, less myelinated with A alpha than A alpha, and A delta is less myelinated than A beta, and C is non-myelinated. So sharp pain is carried by A delta, and the dull pain is carried by C fibers. So if the myelin sheath is removed, then there are chances that because of the hyperexcitation of this fiber, there are chances that there is a leakage of the action potential from the superior vessels, superior nerves to the pain fibers. So the current can leak, the action potential can leak down, and by simple proprioception, this is carrying the proprioception, this is carrying the fine touch, but because of the leakage to the pain fiber, whenever there is a fine touch, the pain fiber will carry the sensation to the central nervous system, and it is perceived as severe pain. Similarly, a fine touch, if the currents are short circuit and it involves the A delta and C fibers, so the stimulus is for fine touch, but they will carry the pain fiber and it is expressed as pain. So this was the mechanism of how the pathology is developed and what happens when there is constant irritation of the sensory root with the anomalous vessel. Now coming to the management part. Management part, we will divide the management part as medical management and surgical management. So first we will deal with the medical management. In medical management, we will have certain drugs which will actually block the development of the hyper excitable state of the nerve, or we can say that by the use of these drugs, the excessive action potential which is developed because of the irritation, we can suppress those action potential by use of these drugs. And the most common drug which is used in the management is your carbamazepine. And we can also use phenytoin sodium. We can also use phenytoin sodium. Now we can also use lamotrigine. What is common in between all these three drugs? All these three drugs are sodium channel blockers. All these three drugs are sodium channel blockers. So what is the function of sodium channel? Actually, this is the nerve, and suppose there is a resting membrane potential of minus 90 millivolt. Resting membrane potential of minus 90 millivolt. Now, if any action potential comes, if any stimulus come, then what happens that this resting membrane potential jumps towards the threshold potential. This jumps towards the threshold potential. Suppose it is minus 70 millivolt, and you all know that this is the potential at which voltage gated sodium channels open. So suppose this is a sodium channel. This is the first sodium channel. This is the voltage gated sodium channel. It is in the resting state. This is in the resting state. What happens in the resting state? That it is closed from outside and it is open from inside. So this is the active gate and this is the inactive gate. As the sodium channels are closed from the outside, so sodium cannot penetrate inside the nerve, and when sodium will not penetrate inside the nerve, the negative polarity cannot be changed to positive side, or we can say it cannot be depolarized, and we can also say that the action potential cannot move forward. So whenever this is the resting state of the sodium channel. Now when an appropriate stimulus, when the threshold potential is achieved, what happens? Voltage gated sodium channels open. So this opens slightly and this closes slightly. This will tend to close and this will tend to open. So this will tend to open and this gate will tend to close. So this is the state when the sodium ions can enter inside. Sodium ions can enter inside, and when the sodium ions enter, the negative polarity changes to more positive side, or we can say the polarity has changed, it is depolarized. And after that, what happens when it is purely depolarized? This opens up and this closes up. So again state comes that there is no entry of the sodium inside the nerve membrane, and this state is known as the active state of the sodium channel, and this state is known as the inactive state of the sodium channel. What this carbamazepine or phenytoin sodium or lamotrigine, all are sodium channel blockers. They will enter inside and they will block this inactive state of the sodium channel, and this channel is blocked. It cannot be flipped back to the resting state, and when it is not flipped back to the resting state, the action potential cannot generate, or we can say the train of action potential cannot move. So the function of these drugs are to block the sodium channel at inactive state. So these are some drugs which is used in the medical management. You can start the carbamazepine with a minimum dose of 100 mg per day, and you can increase the dose gradually, and look for the changes which have occurred in the patient. Is the pain is reduced or it has been disappeared? So according to that, you can increase the dose. Once it is stable, the pain has reduced, you can taper the doses, and at least it takes 1 to 2 months. If appropriate responses are coming, then it takes 1 to 2 months. You can continue the drug. Maximum dose you can give is 1200 mg per day, but it has side effects. So aplastic anemia is the most common side effect. So we have to go for regular CBCs, complete blood count. This was about carbamazepine. Another group of drug which can be used in trigeminal neuralgia in medical management is your GABAergic drugs. These drugs are baclofen and gabapentin. You all know that GABA is a neuroinhibitory transmitter. It is gamma aminobutyric acid. Gamma aminobutyric acid, it is an inhibitory neurotransmitter, and the function of this neurotransmitter is to inhibit central nervous system activities, inhibitory neurotransmitters. So if this is a nerve and there is a receptor which is known as GABA receptor, any of the drug, these are the GABAergic drugs. If they act like a GABA substance, they bind with the GABA receptors. And what is the function of GABA receptor? That there are two functions of the GABA receptor. First, they will open up the chloride channels. So more and more negative chloride ions enter into the nerve, and it will be more hyperpolarized, more negatively polarized. So there will be inhibition of the action potential. Secondly, it can open up the potassium channels. It can open up the potassium channels and lead to the efflux of potassium. So if more and more potassium will go outside, again there will be more negative polarity inside, and the nerve will remain in the resting membrane state. It will not be depolarized. So these were the medical management regarding the trigeminal neuralgia. Coming to the surgical management. In surgical management, we can go for neurectomies, Neurectomy is nothing but cutting of the peripheral nerve. But before that, we have to diagnose which nerve is involved, which branch of the trigeminal nerve is involved. Either it is mental nerve, or it is inferior alveolar, or it is infraorbital, or it is ophthalmic. You have to identify by simple exercise, by giving a local anesthetic block, and by that you can find out which nerve is the culprit one, and you can go for the cutting of the nerve, peripheral neurectomy. You can also give injection of absolute alcohol. It can also burn the nerve. Then you can go for microvascular decompression. Microvascular decompression, also known as MVD. Microvascular decompression is nothing but it is a surgical technique in which you will enter into the brain, you will enter into the target area, you will identify the anomalous vessel, you will identify the sensory root, and you will just pull up the anomalous vessel, and in between the nerve and the anomalous vessel, मैं कर लेता हूँ. ठीक है आप कर लो, वो आगे का बता देना जो भी है मैं कर लूँगा. So I was talking about microvascular decompression. So it is nothing but you just surgically enter into the brain, and you will you just lift the culprit vessel and put a cushion in between the vessel and the sensory nerve root. You have to, this is a sensory nerve root, this is a trigeminal ganglion, and this is the anomalous vessel. You have to put a cushion. So basically you are decompressing the nerve. It is microvascular decompression. Basically you decompressing the nerve, and it can be of Dacron. It can be of Dacron, or it can be of Teflon. You can put any of the substance structure between the vessel and the sensory nerve root. So it is a surgical technique. Secondly, you can also go for percutaneous. This is also a very percutaneous radio frequency thermal ablation. Thermal ablation. It is nothing but you will generate through a needle, through a wire, you will enter through the foramen ovale from the skin side, the cheek side, you will enter through the needle, you will enter into the foramen ovale, and you will target the ganglion, trigeminal ganglion. And after entering into the ganglion, when you enter into the ganglion, you will just, the needle will produce heavy amount of radio frequency waves, and these radio frequency waves will cause a thermal lesion and block the entire ganglion. So this is one more procedure which can be used. It is lesser invasive, it is not so much invasive, so it can be also used as a treatment modality, surgical modality. And one more technique, that is your gamma knife radio frequency radio surgery. This is nothing but you will put the patient in a closed chamber, and you will make him sit, you will place a certain helmet sort of thing, and what this helmet contains, that helmet sort of thing contains radionucleotide substances, and these radionucleotide substances will produce radiations, and it will target these radiations will target the ganglion, and it will burn it or inhibit or make it non-functional. So nothing, it is not a surgery, and we are not using any knife also, but it is just simply producing the radiations, focusing the radiation on the trigeminal ganglion, and you can make it non-functional with the help of radiation. So these were all the surgical management regarding the disease known as trigeminal neuralgia. So we have discussed about the definition, we have discussed about the etiological factors, we have discussed about the differential diagnosis and the clinical manifestations. And in the diagnostic part, I was want to say one more thing, that before going for all these surgeries, before going for MVD or for the radio frequency ablation or for gamma knife, you must ask the patient for MRIs. A very clear location should be identified, a very clear relation between the culprit vessel and the nerve should be identified, and then go for this treatment part. So this was all about today's lecture. Thank you very much. I'll come with a new topic very soon. Thank you so much.